Every day we see more tents under bridges, more families living out of cars. And while the problems seem insurmountable, the solutions are simpler than you think. We share the real stories and the real solutions of homelessness, what works, what doesn't, and how communities like ours can do better. I'm Baron King, and this is Give Me Shelter. Well, good morning. So this morning I had a doctor's appointment. It was for my annual physical, and I went to the doctor. I had made the appointment, went in, used my insurance. They ran some tests. I'll hear the results soon. But I think it's going to be pretty okay because I try and eat well, take care of myself. I think like most of us, we're aware of our health and try and get to see the doctor from time to time. However, I live a sheltered life. I live in a home. I have access to medicines, good nutrition, and I've been wondering what would my results be if I lived unsheltered, because we're talking about a population that doesn't have access to regular health care, that likely doesn't have insurance benefits, and is exposed to the elements 24/7. And so what we're going to be talking about today is the impact on people's health related to homelessness, and specifically unsheltered homelessness. And I am no expert in that, and so I brought in an expert, somebody I've gotten to know, and this is Dr. Hannah Bujak, who is a doctor in the Chattanooga area. Actually, you and your husband are both physicians, correct?
Yes, we are.
And she has been working with the Regional Outreach Cooperative. So she's one of the rock stars, as we like to say, and she provides street medicine to the people that we serve in remote encampments. So welcome to Give Me Shelter. I'm glad you're here.
Awesome. Thank you so much for the invitation. I appreciate it.
So tell us, what is street medicine, and how does that different from medical practice in a normal setting?
Yes, like your office visit this morning, I suppose. So street medicine is a fairly recent concept and construct. It was actually started in 1985 by Dr. Jim O'Connell, and he is from Massachusetts, Boston, Massachusetts. He was a Harvard grad, and he finished his residency program. And he decided that his first job would be at a homeless clinic up the road from his residency.
Okay.
And so he started there, and he continued to work there his entire life. But through that experience working at the homeless clinic, he realized that he couldn't have follow-ups with his patients, or they wouldn't show up, or he knew they were running out of medications, and he knew they needed them. And so he decided, well, I'm going to go find them. And so he took a team. He took a nurse with him and a social worker, and they went out and just started to find people on the streets that he knew needed care. And so from there, that kind of started this concept of street medicine. And there's an amazing book on him. If you were interested in reading it, or for anyone out there, it's called Rough Sleepers by Tracy Kidder. Amazing book, beautiful stories in there. But it does go through what street medicine is.
Okay.
And so from there, street medicine programs have developed throughout the United States. In fact, a lot of major cities have street medicine programs. And there is a Street Medicine Institute now, which is both national and international, and they come alongside street medicine teams and help them start up. They provide resources. They provide people who actually come out and walk alongside you, basically really working with you to develop your street team. So really a lot of resources out there for this. Again, my journey into this is a different question, I think, but yeah, that's what street medicine is. It is actually taking medicine to unhoused people where they're at. And so pretty much like a house call, but without the house.
Yeah, and probably without a lot of diagnostic equipment and some of the things that you rely on in a normal office setting, right?
Yeah, absolutely a different setting for sure.
Yeah. Okay. So how did you get started doing this?
Yeah, I feel like it was really a God moment. I think he had his hand in this for sure for me. I go to a church and I attend a small group. And one of the members from the small group accidentally ran into a rock star, one of the team members from the Regional Outreach Cooperative.
Okay.
And she got engaged in a conversation with him and just was really enthusiastic about what they were doing. And so invited him to come to our small group at church and talk to us. And our small group is really passionate about doing service projects, going out in the community, doing work, et cetera. And so I was there and I got to listen to him talk for an hour. And I was just sitting there blown away that, number one, in this community, there are people out there doing this work.
Yeah.
There are people who are passionate about this that aren't just, coming down to the streets, once a month to deliver a meal or, making blessing bags and handing them out your window. No, they're on the streets and they know these people. They know all the unhoused people in Chattanooga, which is just huge. And so I was blown away by what they do. And so afterward, of course, I went up and I'm like, hey, how can I get involved? And of course, it came up what I do. And they're like, we've been looking for somebody to do medicine on the streets with us. And so it was back in September of 2025. I got to do my first ride along with them. And it is history since. I've been able to go out every Wednesday with them. And it's been an amazing privilege to work alongside them. I cannot say enough about the Regional Outreach Cooperative. These are just amazing human beings, people who are just dedicated to what they're doing, passionate about what they do, and I really appreciate them as people in this work.
I couldn't say more. I agree with you completely. And I think out of all the avenues to help people struggling with homelessness, I think the people who are working in the encampments have really, really hard jobs. It's not easy work. So you have to love it, right?
Absolutely.
You can't do it if you're doing it just for the paycheck. Yeah.
Yes, absolutely. And burnout can be a big thing in this area too. So these guys have been out there for years doing this.
Yeah. Well, that's great. So walk me through, like, you did this today, right?
Yeah, I just got back.
So walk me through a typical day. What does it look like? How does it start?
Yeah, for sure. So like I just said, the ROC team members are going out on the streets throughout the week. And in fact, about every 2 weeks, they try to see everybody in our local area that is unhoused and touch base with them. And so what they do throughout the week when I'm not there is they find out who needs medical care or who's requesting some medical service. And then they make a list of names and where they're located. And then when I come out on Wednesdays, they have this ready to go.
Boy. Okay.
Yeah. So we meet up at the Regional Outreach Cooperative headquarters and we gather food, bags, and other basic needs supplies to take along with us. And then I take my medical bag, which is full of all the things I can fit into it.
Yeah.
And we go out. And sometimes it's just a pin on the map where we're trying to find this person. And sometimes we get really lucky and we're able to find everybody we're looking for. And other days, we don't. Typically, we're seeing about half a dozen to a dozen people a day.
Okay.
So, the numbers are smaller than what I would see in my office, for sure. But, each time we're able to connect and do that, it's just, it's wonderful to be able to connect with them and find them.
So you already have an idea of how the day's going to unfold based on the information that's been gathered. I mean, it may not work out that way.
Yes, theoretically, yes. But it does change because oftentimes when we go into an encampment and I'm there to see somebody, there's the, oh, by the way, and like, I love the community with the homeless because they tell on each other.
That's what Casey was telling me.
So yeah, you'll go in and we're seeing this one person and then all of a sudden it's like, oh, well, so-and-so has, this burn or this wound or whatever. Can you take a look at him too? Or I've had this cough. Can you take a look at that? Can you evaluate it?
Yeah.
And of course, that's what we do. What we do is we just go with it and we see everybody that we can.
Yeah. So how does the work in the encampment setting, what are the big differences between that and a normal office setting? Like when you think about the challenges or the contrast between those two, what sticks out to you?
Yeah. So, In a regular medical clinic, you have all the accoutrements of medical care there at your fingertips. And so we have, our computers, we have all the medical supplies to take care of wounds and skin conditions. We have medications that we can give in the office. We have IVs, we have injectables. We also have nursing staff there. We have lab techs there. So we have a lot of resources right there.
Sure.
We've got EKG machines and all the other things that, we can really wrap around a person for care. So when we go out to the streets and, we're going into these encampments, there's none of that. It's just my bag and me.
Yeah.
And I do try to fit in as much as I can, into that bag. But yeah, so we'll be standing, by a stream. We'll be sitting on a forest floor. I'll be tucked halfway into a tent, doing my work and taking care of these patients. So it does not look like the traditional office setting, but it truly is an office visit. We do the same things. We talk about what's going on with them. We get history. They tell me their story, and I listen, and then we try to come around them as best as we can to treat what's going on with them. I think one of the biggest things right now for me is working with trying to coordinate services, other services for them that I can't do and I can't provide for them. So that is the biggest challenge that I have right now.
And what kind of services are you referring to, like diagnostics or
so,
specialties? Yeah.
Right. Yeah. So, lab work, diagnostic things such as imaging that they need or seeing a specialist. I saw someone out on the street this morning who really needs to get in with a dermatologist for a possible skin cancer. And so trying to coordinate that care for him. And fortunately, he does have insurance. And so it'll be a little bit easier for us to coordinate that for him.
Yeah.
But some people don't. We need to start there. So we need to start to get them, their insurance card. We need to get them down to the homeless healthcare clinic that can help work with them to get that. Or even it's as basic as they first need their ID because they've lost that. And so sometimes, it's a lot of steps to get them to the point where they can get that care.
Yeah.
And so we need to start with them and just, progress as we can. Not as fast as I'd like, but certainly to try to progress in that way.
So I've got a number of questions about your experiences with this. Just generally, what sticks out when you think about the experiences with your unhoused patients, your unsheltered patients? What are some of the things that have stuck out?
Wow. I must say, I love working with this population. And if you haven't, I would highly encourage you to do so because when we get proximate to people like this, we really start to see their story come through and we humanize them again. And so I think for me, the biggest highlight is just being able to meet them, to hear their story, to build a relationship with them. But I've had some great experiences as well from the medical side. I had this one gentleman, we'll call him John, and he had suffered a knife wound to his hand. It actually went the whole way through, and a large laceration, about 5 centimeters or so, on the back of his hand, so from the front of the hand to the back of the hand. And fortunately, within a few days of that happening, he did seek emergent care through the ER. But when he was discharged, he wasn't able to get the medication and the antibiotics that they wanted to send home with him. The prescription was sent to the pharmacy, and because of barriers in transportation, he wasn't able to go there and get those. So I saw him, I think a week out into this, and of course, when I got to him, it was infected. The wound was oozing and draining, and there was a lot of dead tissue there as well. The sutures had pulled apart. And so I was able to kind of come along with him, and we were able to clean it and debride it and rebandage it. And then I was able to hand him antibiotics to take and to start. And so we kept following him weekly. We'd get out there, do wound care changes and dressings, and then, of course, give him some supplies to take care of it when we're gone.
Yeah.
And then just kind of keep up with him. And eventually, it healed completely.
Wow.
There were many points along the way where I thought he might need an amputation of, 1 or 2 digits of that hand because of how severe it looked.
Yeah.
But through the ROC team and their persistence and their consistency coming out and making sure that we found him, we were really able to, save his hand. I really, do think that it's the work that we're doing is not insignificant.
No,
out there,
that's a drastic change in somebody's life
yeah.
to lose fingers. So
Yeah, exactly. Yeah. And he's got this great story of what his work used to be, but I'm not going to go into that just for privacy reasons.
Yeah.
But he uses his hands a lot.
Yeah.
Yeah.
Wow. So are there certain injuries or illnesses that you see more than others?
Yeah, absolutely. So we see a little bit of everything out there. And of course, we also see the same things that I see
Okay.
in my medical office. So we'll see chronic disease,
Okay.
uncontrolled diabetes, cardiovascular disease, high blood pressure, all the things that you would normally see. However, when we see it out there, it's significantly worse.
Okay.
So for people who live on the streets who are chronically homeless, age-related health conditions typically show up 10 to 20 years sooner.
Yeah.
And so that alone means when I'm out there and I'm seeing diabetes in a 30-year-old, like I saw this morning, it's much more advanced or it's uncontrolled because of the barriers to care and the inaccess to care. Yeah. And so that makes a big difference in how we're going to come alongside and treat that and manage that. So yes, so we see chronic diseases, but most of them are unmanaged or poorly managed. But then we see so much else. We see issues from substance abuse. Mm-hmm. We see periodontal disease and dental disease, huge out there because they can't get to the dentist. And so not everybody knows, but when you have bad dentition, that relates to your overall physical health as well and can in fact lead to cardiovascular risks, et cetera. Right. And so all of these pieces really start to affect their health in the long run. And so another thing that we don't talk about is the chronic stress of being homeless and how that affects your health too. So people who are chronically homeless have about a 20-year less life expectancy, 20 or more, and actually for women it's a little bit more. The average age of someone who is homeless is between 48 and 52 when they die. So so that's a significant reduction in age, where most of us men are early 70s, women are later 70s is their life expectancy in the United States.
I become, unfortunately, acquainted with a phrase that a year ago I didn't even know, and it's that homelessness is the #1 geriatric accelerator.
Yes.
And I think exposure, your body constantly fighting off germs and diseases, everything just causes that aging process to.
Yeah, absolutely. Yeah. I mean, just think about general just being able to clean yourself or take a shower. I mean, that's going to contribute to your health. The food that you're eating, okay? So there was a statistic that I saw recently that on average, a homeless person will have about 8.6 meals a week. And so that's significant.
Yeah.
If you're not getting proper nutrition or proper food, let alone calories, that's going to affect your health, your medical health. The elements, okay? Right. So being out in the cold puts you at risk for frostbite. It also puts you at risk for burns because you're going to develop a heat source, and that's usually an open flame. And so when you have an open flame, that's putting you at risk for burns and tense burning, et cetera. And so, this past winter, we did see a lot of burns, unfortunately. But all of those things, the elements, rain, okay? So foot care is another big issue that we see on the streets because of wounds and sores and chronic infections and fungus. All of those things are issues because, number one, they're on their feet all day for the most part. You know, that's their mode of transportation. So they're on their feet all day. And then number two, they often don't have good fitting footwear.
Right.
And then number three, the elements. And so those shoes have gotten soaked. Their feet are soaked. And so they can't change those out all the time. They can't keep their feet dry. And so the elements play a role in their health as well. So all of these pieces, affect their overall medical health. Of course, we didn't mention mental health. Of course, that is out there for sure. And I would like to talk a little bit about that. Mental health, of course, everybody does correlate that with people who are homeless. But one of the things I think about as I've gone out there and, been alongside the people living in these conditions is I've asked myself, what would it be like to live like this,
Right.
And so my family loves to camp. We love to go over to the Smokies, camp for a few days, live it up. It's beautiful. It's wonderful, right? But after 3-4 days out there, I am ready to come home. I want that warm shower.
Yeah.
I want my soft bed. I want a roof over my head to protect me from the bugs, from the sun, from the rain, from all the things, right? Can you imagine living every single day in a tent? And you're not 30 years old.
Right.
You're 50 or maybe older, and you've got arthritis, you've got back problems, you've got foot problems, you've got joint problems, you have chronic medical disease, and you're living in a tent every single day. What do you think that would do to your mental health?
Well, I'm glad you brought this up because this topic comes up a lot. And I think the average person probably believes that somebody's prior mental illness is a driver or a significant cause of homelessness. And in some cases, I think it's always a component. But I would also argue that it's kind of a chicken and the egg argument because in my previous nonprofit, I worked with repeat offenders coming out of the prison system, coming into residential transition programs. When they left the prison and came to us, we would have their medical records. And I would say 90 to 95% of the people coming out of the prison system into us had a diagnosis of anxiety, depression, and I'd say about 70% had bipolar. And the previous leadership at the organization, their process was, well, let's keep them on their medications. And I said, you know what? I would argue that a prison setting, those emotional responses are highly appropriate for that setting. Because if I was in prison, I would be depressed and despondent. I would be anxious. And my mood would be all over the place. And so what we found was 30, 60, 90 days after transitioning into our residential programs, most of the symptoms started to go away. And so I think that's really important for our listeners to understand is we're not dismissing the importance or the value of addressing mental health and mental illness in our population, but what we're also saying is it's not correlation doesn't prove causation.
Absolutely.
And that we may have people that are experiencing symptoms that are highly appropriate for the setting that they're in.
Absolutely. Absolutely. Yeah, I would echo that for sure. Yes, mental health issues are out there, but statistically, if you look at the difference, they're no higher than the general population.
No, they're not.
And but yes, it's compounded by living out there. And, like I just said, I mean, what would my mental health be after living on the streets for that long? I'm sure I'd have several of those DSM-5 criteria, for sure. So yes, have I seen patients or seen homeless people who are out there who have, these are really sad cases, but I have seen multiple people who are now homeless because their caregiver passed on.
Right.
And so maybe they have a mental health disability or another disability, and their care provider has moved on. So there are cases like that for sure. But mental health is also significantly compounded by the environment that they're living in. And you think about particularly for women, right? Yeah. So the number one cause for women to be on the streets is violence against them. Sure. Right?
Sure,
so that's why a woman
they leave
is
a dangerous
homeless.
Situation.
Is because of violence. And so these women will have PTSD, emotional trauma, et cetera. And all of that affects mental health, and that subsequently affects medical health too. Absolutely. It is an issue. But, obviously what I would love to see is psychiatric street medicine in this area would be phenomenal. Or, certainly more robust services for psychiatric care. And of course, that's hard nationwide. But there is such a thing as psychiatric street medicine. So just putting that plug in there for anyone who's listening, who's a psychiatrist, please come talk to us.
Dr. Hefner on our staff is currently working with a number of different groups to try and build out a project involving Erlanger, involving some other bigger names. The biggest problem is our state capital, that our lawmakers don't want us to be Medicaid expanded. And that most of the states that are running really effective street psychiatry programs are in Medicaid expansion states, which is, if you're not familiar with that term, it's just a level of medical care that is has to be supported by state revenue. gives more resources to people that are living at or below the poverty level. And our state legislators in Tennessee have said we don't need it. But that's a topic for a different episode, I think.
Yes.
All right.
Yeah, for sure.
So we've talked about the common things you've seen.
Oh, yeah.
What
Sorry.
are-
and
what
I
are the-
probably didn't finish that,
Oh,
actually.
go ahead.
I
Go
probably
ahead
did
and
not
finish.
finish. So we went to mental health. The other big piece of medical issues that we see out there, of course, are skin issues. And so a lot of, abscesses, boils, cellulitis, infections. Of course, we talked about the foot care piece, but wounds, lacerations, cuts from just their environment. I saw a woman this morning who had a bad bike wreck, and so she had a large laceration in her arm that we took care of. And so a lot of these things that are, pretty easy to treat in my office, right? You're like, okay, get your antibiotics, put this on, and you're good to go. And they heal up really quickly. Well, in this setting, these can go south really, really fast and quickly.
Why is that?
So, because you don't have the resources there available to really care for these wounds. And so, number one, where's your running water? How do you clean it out?
Yeah.
How do you stay clean? How do you keep that wound clean? How do you prevent it from worsening? Access to care, trying to get into medical care, getting the antibiotics. And so for these people, we follow them up pretty closely because we want to keep them and we give them the supplies because we want them to stay on top of it. And it takes a lot longer to heal than it should. In my office, a week or two would be all better. Here, 5-6 weeks later, and we're still dealing with the same thing.
Right.
It's taking that much time to get better. And they can go south fast. And because the homeless have priorities such as finding food for the day, getting clean water, knowing, if they can make some money or taking care of what they need to, their health actually comes significantly lower on that list of priorities.
Choices.
And so when they think about that infection on their leg, it'll wait another day, And so there's that aspect to it as well.
There's a common misbelief that people are homeless largely because of their poor choices. And I would argue that sometimes the people that we work with only have poor choices to make. And so when you're trying to choose between taking time to clean and elevate a wound or get food because you're starving, those are tough choices to make.
Oh, absolutely. Yeah, absolutely.
All right. What is the wildest injury or thing that you've seen in street medicine, that blew your mind?
Yeah. Oh, man. So we did walk into one encampment one time, and someone came running up to us, and they're like, "Oh, you're a doctor. Can you come?" There's someone who just cut their hand. And so sure enough, someone was using a knife, and they had slipped, and they had a large laceration, bleeding actively in the moment. So I was able to get in there, grab on my sutures and my lidocaine and get them sutured up again. And so that was rewarding, but that was pretty much in the moment. Really bad infections, that are just heartbreaking because
I'm sure
we have so much medical care in this community, right? We have 3 major hospital systems.
Yep.
Robust health systems, world-renowned hospital systems, if you will. And we have multiple urgent cares. We have multiple other medical offices here. And for an infection like that to progress and to get to that point of, needing an urgent care, or if it's gone into the bloodstream or becomes septic, et cetera, it's just unconscionable. It's unthinkable to imagine that just within less than a mile of some of these, healthcare systems that we have patients who are out there like this. And so, it's hard to put those together.
I would guess that you're seeing some injuries and illnesses that aren't necessarily different from what you see in the office setting. But I would imagine in some cases the severity is much more severe due to the exposure.
Absolutely.
Yeah. All right. So we still have dozens of questions, and we're really using our time well. But my audience, we like to keep this to about 30 minutes. So this is going to be the end of part 1. Thank you so much for coming in. Folks, we're coming right back in 2 weeks with part 2. You're not going to want to miss it. Dr. Hannah, thank you so much for what you do, the heart that you do it with. And our unsheltered neighbors are very fortunate to have you. Thanks for listening to Give Me Shelter. If you made it this far in the episode, I invite you to share it with at least one person today. because change happens one conversation at a time. I'm Baron King. We'll see you next time.